All right, well, welcome everybody to the AMETHIST Penn first virtual seminar. We are the implementation science hub of the Improve initiative that's funded by the NIH. And hopefully you all are here because you know that or know a little bit about that. We are going to introduce you to our initiative and tell you a little bit about implementation science as it applies to maternal health. My co-director and partner and MPI, Rebecca Hamm, is here as well. And so the way this will work is that I will introduce the initiative. I'll tell you a little bit about myself, and then I'll hand it over to Rebecca, who will tell you about herself and tell you about some specific applications of implementation science to maternal health. We will be monitoring the chat, so feel free to put questions in the chat, and there will be time for questions as well. So we'll go ahead and launch into this. By way of disclosures, these are just mine. Dr. Hamm will tell you about hers. I have current grant funding from the agencies listed on the screen. No financial conflicts of interest because I haven't figured out how to monetize implementation science just yet. But if you all figure that out, please do let me know. So I want to start off first by telling you about what this initiative is that is meant to support the NIH Improve initiative through implementation science. So first I want to level set and make sure everybody understands what the Improve initiative is. This is an effort that was started by the NIH in 2019. Improve is an acronym that stands for Implementing a Maternal Health and Pregnancy Outcomes Vision for Everyone. And the stated objective of the Improve initiative is to reduce preventable maternal mortality, decrease severe maternal morbidity, and to promote health equity. And I don't have to tell this audience just how dire a situation we are in the United States with respect to maternal health outcomes, maternal health equity. We are doing very poorly compared to other high-income countries, and concerningly, we're doing worse over time as opposed to better, as we are in many other health conditions that you're actually seeing improvements over time. We're doing worse in maternal health, so there's certainly something that needs to change. So the NIH Improve initiative was stood up to help address issues around maternal health. It has a number of different components to it. And so I just want to center what we are doing in the context of all these other initiatives that started closer to when the Improve initiative got launched in 2019. What we are a part of is that core, that middle in the yellow, which is maternal health research centers of excellence. But all of this work is done to support many different approaches to improving maternal health. So the newest part of this initiative that was funded just this summer, the notice of funding opportunity came out in late 2022, and then many of you scrambled to put together something because this seemed like and is an unparalleled opportunity to contribute to what we know about maternal health and maternal health equity. But the NIH stood up these 10 centers of excellence. There were initially going to be 7. I think there were so many amazing applications that they wanted to fund 10 to really capture the landscape of maternal health across the country in many different populations. You'll see the geographic spread here. And each center, you're going to see the corresponding institution, but each center is partnering with other institutions as well. So there's really quite a lot of geographic breadth in this group. But you'll see the research centers of excellence around the outside of that circle in the green dotted ovals. And in the middle, there are 2 hubs that are meant to support the Improve initiative. One hub is centered at Johns Hopkins, and that's the Data Innovation and Coordination Hub. And then Rebecca and I lead the one that's centered here at Penn, which is the Implementation Science Hub. And that's what we're going to tell you more about. But we're really meant to support all the 10 centers of excellence. So AMETHIST is an acronym that stands for Achieving Maternal Equity and Transforming Health Through Implementation Science and Training. If you are able to perceive the differences in colors, the purple is meant to be maternal health, the orange is equity, and the teal is implementation science. We have organized our hub into 5 cores to help us do the work of supporting the centers of excellence. Rebecca and I run the admin core together, so we oversee AMETHIST in total. And then we have an equity core, the design core, policy, and training, and I'll tell you a little bit about each of these. So we're really excited about this whole thing. And if I don't sound excited, it's only because I was up late last night, but I swear we're really, really excited about this. And I'm going to walk you through some of the things that we're most excited about. So with respect to the equity core, what we envision this core as doing is providing consultations on equity to the centers of excellence. Now, we know that each center has a lot of expertise in equity, community engagement, stakeholder engagement. And what we really want to do is kind of organize across the centers under an understanding of how to do this well. So we want to learn from you and then also share learnings with you as we do this work. One of the areas of consultation that we imagine is going to be consultations on integrating equity considerations into learning health systems, specifically electronic health records and other things that the learning health systems do. There is also a training piece. We're going to get to that a little bit later, and I'm looking at Ms. Nicole Thomas there, who's running one of those programs. I'll tell you about that in a moment. But another key feature of the equity core is what we're calling the Equity Advisory and Oversight Board. So the EAOB, we're conceptualizing as a data safety and monitoring board for equity. So for those of you that have done clinical trials, you know that a DSMB is an external body that's meant to review what's happening in a study and figure out whether it's being done safely and ethically. The same concept applies here, where we're asking or will ask the centers of excellence to present to us annually to help us understand how they're integrating considerations of community stakeholder engagement, stakeholder perspectives into the work that they're doing. And again, we want to learn from what the centers are doing, but also want to share ideas about how to do that work more meaningfully, sustainably, robustly, and integrating community members, patients, caregivers, community groups into the work, into the research work at all stages. You'll see that there's representation from lots of different folks with different perspectives, and that's really what we're hoping to harness as we learn across the network about equity. The design core is the heart of the consultation and technical assistance that we offer in Amethyst at Penn. And so the design core is led by Rebecca and also Elisa Stephen-Shields, who's our faculty biostatistician. One of the key features of the design core is our consultant panel. And so when we were putting this together, we realized that many of the centers would hit different aspects of health, and we weren't exactly sure what folks would need. And so we wanted to create essentially a menu of expertise so that people could access folks with expertise in all of these different areas. So again, you'll see implementation science at the top in that sort of light blue, tealish color, equity and community engagement in orange, and maternal health in purple. The idea is that people with these areas of expertise will help you think through implementation related issues to your research. So whether it's what study design might be appropriate for an implementation study, theories, models, frameworks, outcomes, use of qualitative and mixed methods, use of advanced statistical approaches. We have lots of expertise on our team to help you think through the projects. The next core is the policy core. So this is led by Sindhu Srinivas and Sally Chan. The idea behind the policy core, it's really policy and dissemination and communication. We want to help the centers of excellence and all the people in them, including the trainees, effectively disseminate the findings of their research to the world. And I think as researchers, we're very good at doing peer-reviewed publications. We're not always so good at talking to people in language that's actually understandable and generating findings that have immediate policy relevance. So what the policy core is meant to do is to help you all with media training so that as you get requests for interviews, you sort of understand how to approach that and effectively communicate. Doing op-ed writing, blogs, white papers, other types of products that are meant to go to the public that aren't necessarily to an audience that's used to reading peer-reviewed literature. We're going to stand up a policy day every other year where we bring lawmakers, policymakers, and or their staff in with researchers and facilitate discussions so that each side sort of understands where they're coming from, where the other's coming from. And then we have a patient partner, Deborah Grandison, who is integrated throughout this, but her specific expertise is in telling her story as someone who had adverse outcomes after pregnancy. And so she wants to help other patient partners be able to tell their stories effectively as well. Then the training core is I lead with Rebecca Clark, and this is part of the training course. So we're going to have monthly seminars so that we can talk about issues related to implementation science. There will be other workshops with Penn partners, including the Center for Evidence-Based Practice, which will help with evidence synthesis, the Mixed Methods Research Lab, which will help with qualitative and mixed methods research, the Leonard Davis Institute of Health Economics, which will help with media training, and there's a few others as well. We have created access to the Penn Implementation Science Institute, which is a 4 half-day long boot camp that happens every year in June. So that is, we've done it 7 times now. We'll have our 8th one this coming June, but we have slots set aside that we're paying for folks to join the ISI from each center. And then certainly if you all want to send more people, you can. The program I mentioned before, run by Sarah Solomon and Nikki Thomas, is the REACH Investigator Community Team Training. REACH is an acronym that I think stands for Research and Equity and Academic Community Partnerships for Health. But the idea, this springboards off of a longstanding community scholars program at Penn, and the idea is that we want to take teams of community members and investigators that are based at the centers and help them learn together how to be effective partners. And so they're standing that up this year, and then we will launch it next year. We'll also have a pilot grant program for early stage investigators, which will include postdoc fellows. That'll start late next year, and then an annual gathering at Academy Health, specifically the Conference on the Science of Dissemination and Implementation in Health, which we often call the D&I Conference, and that happens every December. And we'll be meeting this December on December 10th as part of the IS for MH group that Dr. Hamm leads, the Implementation Science for Maternal Health. We also have a research aim, and the research aim of the hub is to investigate the determinants of implementation success across the network. And I think this is one of the things that I'm most excited about, because we get to do research on the researchers. And so there's more to come here. This will be led in part by me, but also Laura Ellen Ashcraft, who's one of our members, and then Rebecca will do part of this as well. But we'll be doing interviews, inviting people to do interviews, and collecting other types of data to understand what helps with implementation of maternal health focused interventions and what might hinder successful implementation. Basically, we're trying to understand the determinants of success across those centers and characterize barriers and facilitators so that we can understand that more and apply those understandings to facilitate the implementation research in the future. So that's Amethyst. I wanted to start with an overview so that you understand who we are and why we're here and what we're doing. I do want to give you a little bit of a primer on implementation science, because I realize that folks have different levels of exposure to it. And so just very briefly, I'm going to go through implementation science, just sort of the high points, and then set Rebecca up to talk a bit about how implementation science, like specific applications of implementation science to maternal health. So as we pivot, I want you to put yourself in the mindset of how we get people and systems to change their behavior. We know that there are many evidence-based practices in maternal health that are underutilized. There are also some that are overutilized that probably need to be de-implemented. I am not an OBGYN. I work with them in the hospital, but I do not pretend to know this. So I'm going to, Dr. Hamm is our expert here in many things, especially this, but I just wanted to call out some of the evidence-based practices that come to mind, at least for me, as I think about implementation science and maternal health. What the field ultimately is trying to do is to bridge the evidence to practice gap. So the idea is that there are interventions that we ought to be doing or maybe ought not to be doing, but we have a sense of how care should look. And then there's reality, and there's a gap. And what implementation science is trying to do is to bridge that, is to bring those two together. There are many definitions of implementation science, but my favorite comes from Ann Sales, who I think of as one of the godparents of the field. And she defines implementation science as the study of human behavior change under organizational constraints. And one of the reasons I love this definition, other than it being concise, is that it sort of signposts all of the fields that have anything to do with behavior change will apply to implementation science. So psychology, sociology, anthropology, public health, behavioral economics are all going to apply. But also all of the concepts that relate to organizational change are also going to apply here. So organization theory, management theory, change management and organizations, all of that is going to apply to implementation science as well. And the magic here is that we're pulling it all together and trying to make sense of the learnings from those various different fields as applied to implementation. It is admittedly a mutt. And so if you think about all of the fields that feed into implementation science, it's these and many more. I'd say systems and human factors engineering is one of the newer ones that people are developing an awareness of. I do a lot of implementation research in the acute care setting where workflow is tremendously important and time pressure is an issue. And so human factors engineering, especially for the work that I do, is important. But you'll see, these fields are all much older than implementation science, which is, depending on who you ask, 20 or 30 years old. So I don't mean to pretend that everything that we know is new. We are pulling quite a lot from more established disciplines. Implementation science is conceptualized as late-stage translational research. So if you take sort of the NIH's conception of translational research, where T0 is basic science mechanistic work, all the way over to T4, which is translation to the community, implementation science is really in that T3, T4 realm, where we're translating into practice and we're translating to community. Another way to think about implementation is using this subway that I developed in partnership with Jeff Curran, who's at the University of Arkansas for Medical Sciences, and Renad Baitis, who was at Penn for a long time and is now at Northwestern. Basically, we created this sort of heuristic, or this useful tool for people to understand whether their thing, their concept of interest, could be studied with an implementation science approach. So the way to think about this, if you've been to, DC or Paris or London, or, you've seen a metro, hopefully the map will look familiar. Sort of start off on the left and you ask yourself, what's my practice of interest? And so it could be something like anemia management in pregnancy. And that's not specific, but let's just say anemia management in pregnancy. And we'll ask ourselves the specific interventions that have been used to address anemia in pregnancy. Have they shown efficacy? At a mechanistic level, do they work? And if we didn't know the answer to that question, we would want to figure that out. And that would be efficacy research. You would want to design implementable interventions. And I'll mention that again a little bit later, but that's not implementation science, that's efficacy research. If we know that mechanistically it works, then we ask ourselves, has it shown effectiveness? So in the real world, in less strictly controlled settings, does it work? If we don't know that, you could do effectiveness research, but increasingly people are doing hybrid effectiveness implementation trials because we realize even if we're not sure exactly if it works, we kind of need to figure out how to get people to do the thing that we're interested in. But if you know that it works under all circumstances and you're just trying to figure out how to get people to do it, that puts you in that lower right corner. And then we're trying to understand context, figure out implementation strategies to use, and everything in that lower right corner that looks green if you can perceive red-green differences. That's all implementation science. So what makes it different from other sort of approaches to health services research or clinical research? There are 5 key features that I want to highlight for you. The first is that in order to play in the sandbox, there has to be an evidence-based thing to be implemented. There's a little bit of tension here because what counts as evidence is a question. That's something that we're going to address in our training core when we do evidence synthesis work. But usually there is a thing. Either there's an evidence base that says it shouldn't be done, or there's an evidence base that says it should be done, but we have a practice in mind. The second key feature is that we do this work in partnership with patients or clients, communities, and stakeholders. This is not armchair science. This needs to bring all stakeholders to the table in order to be valid, to be acceptable. And so whenever we run into judgment calls, which we do a lot in implementation science, we resolve those issues in partnership with stakeholders. Thirdly, our outcomes are different than traditional effectiveness outcomes. And one of the ways that Jeff Curran talks about this is he talks about that practice of interest as a thing, and the implementation strategies are the stuff we do to get people to do the thing, and implementation outcomes are how well people do the thing. So our outcomes are concepts like adoption, appropriateness, feasibility, fidelity, sustainability, and they're different than traditional effectiveness outcomes like morbidity, mortality, length of stay. We are certainly interested in those effectiveness outcomes, but the implementation outcomes are earlier in the causal pathway, and so we pay a lot of attention to whether those are actually happening. The fourth is that we love context. So contextual nuance, how things play out in South Dakota versus Florida, how they play out in rural versus urban settings. We care a lot about that because that helps us understand how to reliably get evidence into practice. And so things that might be perceived as noise in a randomized controlled trial, we actually see as information. And then finally, we use specific language, methods, theories, models, framework, strategies. And this can be a little bit daunting when you're new to the field, but it does help us communicate across settings. And so some of that language is really important. And part of the role of our Amethyst Hub is to help all of you think through how to apply some of these concepts to the work that you do. There are some focal areas in implementation science that I'm not going to go into in depth, but I just want to call out that even within this newish field, you're seeing people differentiate and have specific areas of focus like those listed here. And increasingly, we're focusing on equity. I've mentioned it a couple of times, but more recently, there's been an explicit focus on equitable implementation to make sure that we're not reproducing evidence to practice gaps or reproducing a sort of rich get richer situation. There are some tensions in implementation science that I'd like to highlight. We are trying to generate knowledge about how to facilitate behavior change. We do that by studying specific settings, but then we're trying to create generalizable or transferable knowledge. And exactly how to do that is a little bit tricky, but it's something that we are still grappling with. You might do a large implementation trial in 10 sites or 20 sites, and then try to learn something about how the world works from that. And so how, what exactly is generalizable? Is it the findings? Is it the methodology? That I think we're still grappling with. We know that evidence can be imperfect. In my world, in anesthesia, there are very few randomized controlled trials that are reliable. In maternal health, it's hard to research on pregnant people for lots of reasons. So sometimes we are dealing with evidence that has some flaws to it, and we have to figure out when things are ready for implementation and when they aren't. And that's sometimes something we have to grapple with it for every project. Spread and scale is something we're still trying to figure out. When something works somewhere, how do you get it somewhere else? Capturing and understanding complexity and how different factors or contextual issues might combine to either facilitate or undermine implementation is something we're still working through. And balancing speed and rigor. Everybody wants to change yesterday, especially given the state of maternal health in the US. But we also want to do this work rigorously and reliably. So how do we kind of balance those two? Ongoing challenges. Equity is important, but also a challenge because people sometimes, researchers, well-meaning researchers can sometimes sort of check a box and not actually meaningfully integrate folks. And so figuring out how to do that is something we're still working on. And then figuring out how to minimize evidence to practice gaps and not create or widen them. And then figuring out when things are ready for implementation and what standards of evidence should be used. So finally, I want to wrap up and share a little bit about what I think implementation science has to offer maternal health. I mentioned these evidence-based practices. So I want to keep these in mind as I talk through I think it's five lessons that I think implementation science has for maternal health. The first is that I think we need to leverage qualitative data to understand the contexts in which we're implementing. Examples of qualitative data include observations, interviews, artifacts, but any sort of non-numeric data that give us a better sense of what's happening in a setting. In some of the work that I do in hospitals, we're looking at how patient care happens in ICUs. And it's one thing to ask people about it, but it's another to actually go into a setting, look at who's there, how they're situated, how the setting is laid out, and that may give you an understanding of whether something is implementable or not. So if we go to this example of treating anemia in pregnancy, it's one thing to say that you should treat it, but who's doing the testing? Who's administering iron? Where is that happening? How are the settings laid out? Will this actually work? If we can leverage qualitative data, we can understand these settings better and then design strategies that match the setting to help facilitate the use of that evidence-based practice. Secondly, workflow is paramount. Um, the way people organize their work is really important. And often when we have a practice of interest, we're thinking about that, but we're not thinking about all of the other competing priorities that the people whose behavior we're trying to change, we're not thinking about their competing priorities. And so understanding their workflow can help us make sure that the interventions we're interested in actually dovetail with the work of the people whose behavior we're trying to change. So we want to think about systems and not individual technologies or innovations. We want to think about competing priorities. It's really important, especially in this era of burnout and staffing shortages, that we're not making work harder, but that we're trying to make it either easier or consistent. There are lots of ways to understand workflow. This is one approach that we've used in our group, which is to do process mapping. This is a swim lane process map. You don't have to understand the details to see that there's a lot going on here. This is understanding the process of transferring a patient from the operating room to the ICU, but it could be any process on a labor floor. There's lots of different people. So here, each row is a person and each column is a phase in time. And if you come into the setting and you go, I've got a new thing for you, let's just plop it in the middle, you got a bunch of folks that are like, I don't have time for that. I can figure it out. So if we understand workflow, hopefully we can integrate our interventions into these settings more reliably. We also want to match implementation strategies to context. We love education and training in healthcare, but it's not it's necessary, but it's probably insufficient because many of the gaps are not a result of knowledge, but a result of other barriers. So this is work that's being led by Laura Ellen Ashcraft, who's one of our Amethyst partners. This is a concept of implementation mapping where, again, you don't have to look at the details, but there is a systematic approach to characterizing what's happening in a setting. Those are implementation determinants, articulating change objectives, and then designing implementation strategies that match those change objectives so that we can fit the strategies to the context, and the goal is to make the implementation more reliable. Finally, or fourth, bring all stakeholders to the table, understanding that incentives and priorities are going to differ by stakeholders. So whether that's a patient stakeholder, like our patient partner, Deborah Grandison here on the left, or whether that's a clinical partners, like our folks on the right here, understand what their perspectives are and how that might influence implementation. And then finally, design implementable technologies. So we want, even if you're building up the evidence base for an intervention, you want to consider implementation in the process. One approach to doing that is called MOST, or multi-phase optimization strategy, but you want to create an intervention that actually can fit in the setting. And so then you need to understand what the settings look like. Again, I work in a hospital, so I think about the IR suite on the left versus the trauma bay on the right, and I can come up with a technology that might work really well in one, but not the other. So it's important that as we're thinking about these innovations, interventions, technologies, that we create optimally implementable interventions. So that's all 5 lessons. I'm going to stop there.
Okay, so Meghan did an amazing job sort of introducing the concept of implementation science, what it's here to do. I completely agree with so many of the concepts about why we need this so badly here in maternal health, and specifically within the world of maternal health equity work. I'm going to give you just, I spent a little bit of time in my own work, just giving you a concrete example of how you can take these concepts of implementation science, which sometimes can seem a little daunting, a little big, a little theoretical, into an actual planned research project. And so, the best example I know is my own work. So that's what I'm going to give you today. I'm going to give a few examples from other people's work towards the end. But just understand that there's so many ways to take these concepts into the work that you're doing. And this is really just one example of that. So my story is that I started being interested in quality improvement, which I think is how a lot of people get into the world of implementation science during my general OBGYN residency. Essentially, our goal during my residency research project was to implement an OB hemorrhage bundle, which I'm sure many of you know what that is, or know have done that at your sites. It is essentially, a slew of about 15 different practices that are grouped together as being recommended in order to improve outcomes related to bleeding after delivery. And it included things like a hemorrhage cart, a hemorrhage protocol, what medications to use and when, having a code system for it, and calculating quantitative blood loss instead of estimated blood loss being some of the critical ones. And we took this and said, okay, we're putting this into place, right? We created protocols, guidelines for things. We had committees of people who were doing this work together, but essentially we created an intervention and handed it off without really thinking about implementation. And then when I looked at outcomes or did my resident research analysis, I was really looking pre and post without any evaluation of implementation. And essentially what I could say is that it didn't work. We didn't improve, the hemorrhage rate. We didn't improve our blood transfusion rates. We didn't improve people's blood loss. And so what did we understand about this? Very little, because we had so little understanding of the implementation process. Was it that the implementation failed, or that truly the intervention failed? And we couldn't even begin to answer that question the way we collected the data. And so we know that quality improvement, which is a lot of how we all started doing this kind of work, has its limits. You can do plan, do, study, act cycles as much as you want, but you may never get the answer as to why certain things aren't working. And sometimes you can just keep going through that and it continues to be messy. And so why don't traditional QI methods always work? Sometimes they do and sometimes they don't, is that we know that healthcare implementation is so complex. And I will say that maternal healthcare, and specifically where I work, primarily on labor and delivery, implementation is even more complex. We are dealing with multiple patients, really complex teams of people who are taking care of patients, and who are working in a really high stress and fast-paced, high volume environment. We know that clinicians might not always be aware of the most current research. We know that even if they are, organizations and providers might lack the necessary tools and resources to actually get those practices into the patients who need them. and that some interventions, while they might seem efficacious in a big, research study, don't really align with the population that we're actually and community that we're actually taking care of. And so there's lots of factors that are going to affect our ability to implement evidence-based practices, particularly in maternal health. And it's the physical environment we practice in, the socioeconomic and cultural context and its complexity that we practice in, and the health system that we are working with under as well. So here's that example in my work. So this evidence-based practice that we're talking about here today is a practice I've been working on studying for about 8 years now. It's a calculator that can give patients and clinicians a sense of their risk of C-section when they're starting a full-term labor induction. This is for patients who come in with intact membranes and an unfavorable cervix and are undergoing induction either for a medical reason or an elective reason. They've already decided to be induced or their clinician helped them decide that. There are 5 variables that go into the calculation, and it's height and BMI and parity, gestational age, and Bishop score, and it gives patients a risk of C-section. This is an external website. You can always Google Penn induction calculator and it comes up, although we've worked to build this into our electronic medical record since that time. And so you can kind of see a couple examples of what those scores might look like here. So this is what we're talking about when we're talking about implementation for the rest of this study. So we wanted to understand what happens when we actually take this prediction calculator and put it into clinical practice. And so my next piece was just in a single site, sort of doing a very simple study design, again, a pre and post implementation study, looking 1 year before and after implementation of this calculator into routine clinical care. In the first year, there was no use of the calculator, and in the post period, essentially the admitting clinician needed to recognize that this was an eligible patient for the calculator, get the cesarean risk score, place that information next to the patient's information on the labor board so that everyone who was taking care of the patient could see that. The provider would go and counsel the patient using some standardized scripts to help them understand their risk score. But we didn't change management based on this. That was really important. It was about, having information, but not dictating any changes in care. And we did birth satisfaction surveys before and after, as well as provider and patient interviews at study completion, with the idea that this was going to give us some of that implementation data we needed. We selected specifically implementation strategies, and you'll learn a little bit about that as we talk about implementation science over the course of Amethyst. But essentially, implementation strategies are ways to help get your evidence-based practice into care. There's lots of different ways to choose an implementation strategy when you're implementing, and some more advanced implementation studies are not even looking at clinical outcomes at all. Rather, they're comparing different implementation strategies at how best those are going to get something into care. Assuming that the evidence-based practice is clinically effective without even looking at that. In this case, we were really focused on still the clinical outcome, but we wanted to strategically select some of these strategies to help get this practice into care. And so we knew that stakeholder buy-in was really critical here and got a lot of diverse stakeholders together to come up with our workflow and implementation plan. We trained and educated, which we know in implementation science is something that everyone does, but is needed, is necessary to implementation, but it is insufficient alone. And then we did a lot of audit and feedback, which is one of the implementation strategies, some of my work. I specifically study the effect of audit and feedback for clinicians on labor and delivery, how that audit and feedback should be delivered to who and when and how. But in this case, we chose just daily checks on whether the calculator was used for appropriate patients and gave those providers feedback. And when we put this into practice, we showed a significant reduction in maternal morbidity with the use of the calculator. In addition, when we looked across the C-section risk strata, we were able to say that sort of the biggest changes that we showed in maternal morbidity by score of cesarean risk were in those extremes of C-section risk, particularly in the low risk patients and the really high risk patients. And in our data, when we broke that down, we were able to understand that in the really low risk patients, which is really most common to be low risk for cesarean, that's where we showed a significant reduction in the C-section rate, which was associated with that reduction in maternal morbidity, those reduction in hemorrhage rates and infection. And C-sections for failed induction, one of those indications for C-sections, were completely eliminated in this very low risk group. We showed overall a reduction in C-section rate as well. And then we looked at that really high risk group. There was no difference in C-section rate at all. but there was a reduction in the time to C-section by about 5 hours, which ended up being really meaningful in terms of those maternal morbidity outcomes. Again, a significant reduction in hemorrhage rate and infection, which can be associated with prolonged labor and then ending up with a C-section. And it's very rare to be in this very high-risk group. We also showed a significant improvement in patient acceptability through this birth satisfaction scale before and after, and specifically a reduced racial disparity in birth satisfaction, which was really profound in our pre-group and then reduced in our post-group. So how did we get some more of the implementation information? And that was really obtained through qualitative methods, like Megan said. So much of what we do in implementation science can't be so specifically quantitative. And so we wanted to obtain clinician perceptions of this calculator, acceptability, what were the barriers and facilitators to implementation? How did this impact clinician decision-making that we couldn't tell from the quantitative data? How did patients feel about getting this information? And so we undertook first the clinician interview study. We interviewed about 20 clinicians who found that it was overall favorable and it affirmed their clinical intuition. But there was a minority who felt like there was a concern for over-reliance on this and that it was going to be a self-fulfilling prophecy. We understood those concerns. You know, it definitely reiterated those thoughts we had regarding the changes in management that clinicians were making that weren't dictated by the project, but just were helping them make decisions. Primarily in the low-risk patients, it was empowering clinicians to help achieve a vaginal delivery for that patient who was low risk, and therefore preventing the maternal morbidity associated with the C-section. And in those very high-risk patients, it was helping them make the decision for a necessary C-section sooner, therefore preventing morbidity associated with prolonged and failed induction. But that understanding of clinician decision-making we were never going to get from quantitative data. When specifically asked about facilitators and barriers to using this intervention, some of the facilitators were the user-friendly design, but there were barriers we would need to overcome, that it took time to review the results. Sometimes having those high-risk conversations was awkward, and that they needed help ensuring that the patient understood the score. And so from this, we actually gained some concrete lessons learned about how to optimize implementation of this, what we thought was a clinically effective calculator. Next, we interviewed about 40 patients around the C-section risk calculator, both low and high risk patients. And in our low risk patients, we found that counseling either had little impact or provided a sense of comfort for them. And when thinking about our high risk patients, there were some who felt like it increased stress during labor, but others it helped prepare for the possibility of cesarean. And those patients in that high risk, again, which was a rare group, were pretty split. So, we learned about some opportunities for optimization of the calculator from the patient perspective from this interview. We knew that we needed to start that conversation prenatally. That theme came through so profoundly, even if the calculator result was going to change when the patient got admitted. And that's something we hadn't really considered before going down this road of understanding the patient perspective. And so what are we doing with this implementation data now? You can get all this qualitative data to help you understand implementation, but it needs to be applied to the work that you're doing. And so we're embarking on a large-scale study that's going to be a stepped wedge randomized trial. Megan and Laura Allen, who are on here, who are implementation science methodologists, are laughing at me right now because there are definitely some flaws in this overall study design, but we are going to be trying to understand how this calculator works across 14 sites with a stepped implementation across all those sites. But the first year is going to be spent trying to understand how best to implement this, which not everyone has the luxury to spend a year doing, and we completely understand that. But some of these concepts can be applied even in much shorter timeframes. So we're going to spend this first year figuring out a workflow plan and an implementation plan specific to each site, where we're going to select strategies that map specifically to the barriers that those places are going to have. And we have a menu of strategies that places are going to be able to select from. And this is what the stepped randomized rollout sort of looks like over our time period. But eventually everyone will get the implementation. In addition, we're also going to be still looking at implementation outcomes, making sure that this is acceptable to a range of clinicians outside of the single site we interview people at so far. Looking at how often the calculator is actually utilized. And then specifically with this large sample size, we're finally going to be able to do a more concrete analysis by race, ethnicity, insurance status. Are we reaching the populations who are most at need of reductions in cesarean rate and maternal morbidity? Some other examples outside of my work that I think are very worthwhile to bring up, because I know that a lot of some of the centers of excellence are doing work with opioid use disorder. This is an example. a pilot study to determine whether the use of a checklist summarizing best practices could improve perinatal care for women with opioid use disorder. So the checklist being the evidence-based, you can consider it the practice or the strategy to actually get these evidence-based practices into care. This was done by a learning collaborative at 8 sites across the New England area. And then they looked at outcomes before and after implementation to see if there was practice change. They also evaluated acceptability in a qualitative approach. And they could tell that this was integrated a high percentage of the time. Acceptability was overall favorable. And that information is so helpful as they probably try to move ahead with further, more widespread implementation of this intervention. Another example from a couple of friends of mine, Chloe Zara and Lynn Yee, who are maternal fetal medicine physicians as well, and do a lot of implementation science work. This was the mixed methods component of a randomized clinical trial that was randomizing for postpartum navigation services to help improve postpartum care quality. Again, I bring this up because I know that postpartum care is such a huge focus of a lot of the work going on at the Centers of Excellence for the NIH. And they used CFER, which is one of the more commonly used frameworks to think about implementation science. It helps you think about all those constructs and components of implementation that you need to consider in order to have a successful implementation. And they looked at all the facilitators and barriers to the implementation of postpartum navigation services. And by doing this, they were able to find the core components of their intervention. What was the adaptable part of the intervention that you didn't always need? What are some strategies for implementation that we can use as we move ahead? So even in the context of something as early in the subway map of implementation science, like a randomized clinical trial, you have the opportunity to do real implementation work. And so I think that's something that when you think about all of the studies that are going on at these centers, do you have the opportunity to look at some of these outcomes as you're doing your study? A third, I think my final example is another friend of mine, Jennifer Callahan-Koru, who's an implementation scientist PhD. This is an implementation of one of the Alliance for Innovation in Maternal Health bundles, AIM, which many of you have heard of, is one of the organizations that helps with quality and patient safety in maternal health. And this was the reduction in the safe reduction in primary cesarean bundle that they released. And this was their implementation of it throughout Maryland. This is a big bundle. This is 26 evidence-based practices that hospitals can adopt based on their specific needs. So it's a really challenging implementation. And they actually looked at 26 hospitals throughout Maryland who looked at their rates of implementation, as well as they actually looked at the different strategies that each hospital selected to use to get these different evidence-based practices implemented. And so they were able to define the strategies that were most connected to implementation success across these places, and that those were things that could then be spread across to other sites. So these give examples of how implementation science, while again, it can sometimes seem theoretical and maybe not specifically helpful, that it can be concretely important in the type of work that we're trying to do if we ever hope to scale up, make our interventions more widespread, and actually reach the populations that we need to improve maternal health equity. And so my take-home points reflect many of Meghan's from earlier, which is that implementation science can be a very intensive road if you try to do it exactly, rigorously, and right. But there are many ways to take the concepts of implementation science into any research project, even if you don't have years to do this exactly the way that, the rigorous implementation scientist might. And so first, it's like before you implement, look at a framework. There are many frameworks, models, and theories in implementation science, but it is not important which one you pick, in my opinion. Again, Laura Ellen and Meghan might be laughing at me, but I would say don't be overwhelmed by how many exist or get bogged down in which framework. The idea of looking at any framework will help you conceptualize the work that you're doing and help you cover all your bases in terms of thinking about how to make your implementation successful. And so you need to strategize regardless, right? We know that implementation does not work if you just hand it over to the end user, regardless of what the intervention is. It needs to be thoughtful, it needs to be iterative, there needs to be clear implementation strategies picked, and that the best way to do that is to engage multiple stakeholders and to make sure that you have everyone at the table who needs to be there to pick the right strategies. Qualitative research is research too, I think in the maternal health world specifically, and it's probably propagated by some of our journals being less interested in qualitative work. Qualitative research is critical research. This is the research we're going to do to be able to advance implementation in maternal health and, again, actually reach patients who need these things. And so to promote the value of that type of work. I would say recording what you did from an implementation perspective and measuring those implementation results is really important to helping each other try and do these things. When we think about these bundles, right, we know that I think bundles are a good example because they're being promoted by so many of our overarching groups, right? The reduction of hypertension complications bundle, the OB hemorrhage bundle, the VTE prevention bundle. We think about these things and they are being promoted by our groups. Lots of our hospitals are implementing them, but we are not talking to each other about how we're making that happen. We're not recording how we're implementing, how we're engaging stakeholders, what our outcomes look like in regards to implementation. And so if we can, collecting that data on our implementation processes and outcomes is so critical in order to help each other. And I think that's one of the major things that this consortium collaboration within the NIH Improve initiative can really do together. And then I'll say that it's important to also know that studies and implementation might not work, right? Just because an intervention worked in a randomized trial does not mean it will work in the real world. It may not be acceptable. It may not be able to be penetrated for some reason. And that information can be just as valuable to our community. I just added this slide, Megan, so I don't know if you were going to go back to this, but I was just going to kind of cover some brief next steps before we open this up to questions. We wanted to give a good amount of time for people to ask questions. In regards to us and our interactions with the Centers of Excellence, we just started our process of having virtual site visits with each of the centers where we get to hear about the exciting research projects that you're doing and think about ways that we as implementation scientists can help you advance the rigor of that project that you're doing or incorporate these implementation concepts into your work. And also hear about what you're all doing in regards to equity and training from an implementation science lens. And we've done one of our first 10 so far, and it was fantastic. And I'm really thankful to the Delta Mississippi Center of Excellence who allowed us to have them be our first. But we have some more that are scheduled in the coming weeks, and everyone will get reached by the springtime of next year. We have a baseline survey that's going to be coming out to all the centers. That's going to go to the contact PI of every center. But we are, letting them know that we want multiple people to help fill out that one survey. It's something that we are going to hopefully be able to get a sense of the types of implementation concepts you're already incorporating into your work, as well as what you need from us. You probably heard a lot of things today I hope you heard a lot of things today that helped you be interested in how we can help you do your research better. And so there is going to be a consult request form that us and the DIC hub at Hopkins are working on together to create so that you can actually request to work with Megan and I specifically, but also a whole slate menu of specialists in different areas of implementation science and maternal health implementation and populations in need of equitable research so that you can help move ahead. You heard a little bit about the Equity Advisory and Oversight Board, which is our DSMB, like we said, of equity in regards to all the work going on at the centers. And our first EOB meeting is likely going to be in January, and we'll invite 2 to 3 of the centers to present at that first meeting. Other upcoming events is that we will be doing these monthly seminars monthly. So our next one is in November, topic and timing still to be announced. And then we do have this in-person meeting, if you're interested in implementation science and maternal health, that's going to be held at the Academy Health NIH Dissemination Implementation Conference, like Megan mentioned. That's on December 10th from 3 to 5. If you didn't get the invite to that, please let me know and I can send it to you. I can send out the link actually in the chat after this. Okay.